So, welcome to Talking Data Equity for Friday, January 31st. My name is Heather Kraus. I'm the CEO of We All Count, which is a project for equity in data. And you have made your way to our regular Friday event called Talking Data Equity. The point of Talking Data Equity is to provide a community space for anybody that is trying to align the work they're doing with data with the values and priorities and equity goals of that data project and that context. And what we do every Friday is a little bit different. Some Fridays we do a deep dive into like a technique or a way to analyze data or a way to visualize data. Sometimes we have wide open question and answers, ask me anythings. And sometimes we have special guests. And this particular Friday, we have an extremely special guest. We have a special guest that many of you will know and recognize and will be excited to hear from. So I'm going to introduce the special guest in just a moment. But before I do, let me let you know about a little bit of housekeeping. This session is recorded, and it's recorded so that we can share it with people who can't come at this time of day. And the recordings are shared in the We All Count Data Equity Community Forum. I just put a link to that forum in the chat. And that forum is a public good. You don't have to have a membership or pay money or anything to belong there. You can hop into that forum at any time to watch videos. You can also ask questions. There are lots of people who are happy to share their resources and their experiences, the We All Count team included, but probably more valuable than the We All Count team are people working on the ground in sectors across countries and across expertise. So feel free to use that resource when it's useful to you. Second thing is that we have a special guest today, which means that he's going to be sharing some stories and some slides for a 20, 30 minutes, 40 minutes, depending today. While he's sharing his slides and his stories, we ask that you keep your microphone turned off and you feel free to ask questions, make comments, have a chat using the Zoom chat. And we have the Zoom chat set up so that you can either use that drop-down menu set to everyone, which means that everybody who's here and everybody who watches the recording will be able to see your question or comment. If you'd prefer to make a comment privately to me and the We All Count tech team, you can just put my name, which is Heather Kraus, in the drop-down menu in your Zoom chat, and then I'll see your question or your comment, and I'll do my best to amplify it without using your name. Most Fridays, I can't amplify all the questions I get privately because there's too many, but we do our best. Then, depending on how much time we have left at the end of our hour, we will open it up and you can turn your microphone on, ask questions, have conversations, make your contributions. So that's the housekeeping. That's what we're doing. Again, we are thrilled to see you here. We welcome the new faces and we really rely on the people that come over and over on a regular basis. Our special guest today is somebody who has contributed a great deal to Talking Data Equity, and I'm really, really excited and pleased that he's willing to come and specifically share some of the stuff that he's working on. Dennis Wright II is a lead cancer epidemiologist in the Center for Health and Environmental Data at the Colorado Department of Public Health and Environment. Dennis's primary roles are to monitor cancer screenings across Colorado and provide data analytics support to Prevention Services Division. And he received his Master of Public Health in Epidemiology from the Colorado School of Public Health and his BA in Public Health from the University of Colorado. Dennis researches health and data equity and leads topic-driven discussions about socioepidemiology. Prior to his public health career, Dennis spent 15 years in the biotechnology sector, most recently at the manufacturing quality engineer at Pfizer. In his downtime, Dennis enjoys spending time with his wife and his two children, taking on woodworking and DIY projects, solving all manner of puzzle games, and making time to enjoy a good laugh with anyone. So for those of you who are regular Talking Data Equity attendees, you know Dennis well. You're already familiar with this fantastic laugh. And Dennis, thank you so much for taking the time, especially in all of the the I'm not even sure, in all of the ups and downs of the past 2 weeks to join us today. Let me turn it over to you, Dennis. Welcome.
Thank you very, very much for that introduction. And good morning, afternoon, everyone. Um, Thanks for giving me a moment to speak with you about social epi. I'm assuming you can see the slides. Is that correct? Perfect.
Yes, we can see your slides.
All right. Well, so for those whom I've not yet met, my name is Dennis, and as mentioned, I'm part of the Chronic Disease Surveillance Epidemiology team here at the Colorado Department of Public Health and Environment. Now, outside of my official capacities, I hold discussions and lectures about social epi, and I'll explain a bit about what it is and how it views the way social structures and systems affect all of us. But I'd say most importantly, I want to press upon you why such things are measured. Now, this is going to be designed to be a bit math light and more focused on asking the right questions ahead of the stats. I think there's like maybe one actual data slide. Now, this graphic that we have here, this highlights a few of the inputs that social epi looks into. So it asserts that we do have barriers to population health. And it shows that some people are hamstrung on that road to health, and in some cases before they're even born. Now, I'll go over one of many ways that social epi can be applied. Now, in short, my goal is to give each of you just a little voice that gets stuck in your heads anytime you're looking at data. And that'll be your inner social epi. Then there are references and live links in today's talk, and I'll make sure to have the slide deck available for everybody. But to start, I get to give the standard disclaimer first, but there are actually two items to point out. So first, everything we're going to get into today, these come from my own work and experiences and not reflective of CDPHE. I will note though that at individual and team levels, these concepts did help folks dig a bit deeper into the data we work with. Like there's more discussion about who benefits from the data being presented in a particular way. And also there's more in-depth questions about how we can add context to the data we have based on the past and present that lead us to our current understandings. Now, of course, I'm not going to lay claim to all the positive changes that have been made here at the department. Absolutely not. I can only say that the views many of us are taking are in line with the concepts we cover in social epi, and I find that encouraging. And on that note, there are different fields, schools of thought in this field. So just like any other, some people lean more heavily into the statistics side, the sociological side, maybe the demographic side or policy, even historical. And there are tons of topics anybody can latch onto. So don't think that what we'll cover today is the one and only path to this field. It's far from that. Speaking only for me and my topics of interest, this is but one of many perspectives I enjoy, and I'm hoping you will as well. So, oh, I forgot about this one. Yes, this is just a random filter I put on there many years ago. Figured I need to put a little bit of levity into today's talk. Hopefully that works, and you're welcome. My hair was luxurious. So, as Heather mentioned, I'm a cancer epidemiologist, and I primarily give data support to our cancer programs. Now, I'll get into that more in a bit. The team that I work with is a great group of EPIs who specialize in other chronic disease areas. And we all work directly with BRFSS, along with other data sources. And these are the programs that I support. WWC focuses on reducing barriers to accessing breast and cervical cancer screenings. The Comp Cancer program covers statewide cancer prevention and management, and the colorectal program, they also monitor clinical care and screenings across the state. And outside of the cancer work, I provide BRFSS support to our state's alcohol prevention team. And finally, I give technical support to our state's OPHP team. So yeah, I am very busy, but I truly am loving every second of it. And as mentioned before all this, I spent 15 years providing quality engineering, quality assurance, quality control for the production and testing of cancer medicines, along with other biologics, pharmaceuticals, and medical devices. And before that, I was a multi-instrumentalist and songwriter. So you can see I kind of went from arts sciences. And frankly, I think this history is part of why I focus so much on the data and the stories in our work. And since then, kind of paraphrase Leonardo da Vinci, I chose to study the science of art and the art of science. And all of that led me here, where I hope to encourage everyone to get comfortable in the world of gray, where things are messy and complicated, not always what they seem, and where most of life happens. All right, so all that behind us, let's talk about a little bit of what social epi is. This is a definition that came up several years back. And what I want to focus on is that it says each society forms its own distribution of health and disease. And it's an okay definition. It is talking about society overall, but it leaves some stuff out. Unfortunately, we had a more up-to-date definition, and this is the one I prefer, as it better points out the directionality for health outcomes in relation to society. Now, my core interests stand at the intersection of maternal and child health and medical racism. And this often puts me at odds with our healthcare system. Well, frankly, it's hard for me to be happy with a system that's designed to keep humankind moving along, but systematically skews towards those that the designers deem worthy of good health. See, I expect a system charged with human health to aid the most vulnerable among us, just as it does the most privileged among us. So, till that day, and if I may paraphrase one of the smartest people in existence, this system is garbage, and I can prove it mathematically. So I honestly love that part of it. All right, so let's dig into some of the ideas behind the thinking we have here. And first, this is not meant to shade anyone's profession, so get that out the way first. I'm talking in very general terms. Also, some of the vocab we'll use is a bit heavy, but we're only talking about them to provide some exposure to them. There's no test, nothing else coming. So all right, so some biologists, medical practitioners, statisticians, and even mental health professionals can at times get just a little too caught up in both an individual and mechanical outlook on human health. Now, historically, it's this paradigm that's had the largest effect on health policy, and it carries on to today as well. But what this viewpoint fails to recognize is how our social conditions can affect how we even understand biology and medicine, and thereby human health. So let me put it another way. This thinking says that health is a near exclusively individual and behavioral thing. However, keep in mind that this thinking is also subjected to the context of the time and place it developed in. Science, as we all know, is neither 100% free from bias nor from subjectivity. So, for example, these were also considered settled biological factors. Now, some of you may recognize these. Now, these are just model pictures that were developed during the eugenics movement. And this is just one area where the biological paradigm just falls apart. And it shows how achieving good health can be influenced as a product of its time. Now, the biopsychosocial paradigm, I get it, it's a mouthful. What this does is it leans into the messiness that is our human condition beyond the individual, while still acknowledging the role of biology. And this is where social epi sets its focus. I do want to give a quick note about the terminology here. Now, I talk about systems and structures all the time. You probably heard me say something about it already. Now, the terms might seem a bit squishy, but most of us like to distinguish between the two. So at a glance, we could say that the structure of the ACA frames how Medicaid and other related systems are accessed. Okay, so the population perspective, beyond what we just covered, this focuses on the back and forth between what happens within a person and what's happening within a larger grouping, just like in the community. And it then talks about how groups come together to create institutions that we all live by, and how those institutions both make up and impact other individuals. And it's kind of bringing it back full circle. And this is where we'll spend the bulk of our time today, the eco-social perspective. It takes this last view one step further by challenging us to understand the societal drivers for when that interaction affects some communities differently than others. Now, this is adapted from Dr. Nancy Krieger's book that's one noted below, and it covers 4 basic ideas. First is embodiment. This is the literal biological expression of what the tangible world imprints upon us, or just how the social setups physically affect us. Think of it that way. And the pathways of embodiment come from the societal arrangements of the haves and have-nots, and the constraints our biological systems are under, which are shaped by a changing world. So think of it like the difference in care received if one person has private insurance and another person has Medicaid. So now this cumulative interplay line, this should seem familiar, especially to those who study infectious diseases. Now, in social epi, the exposures, susceptibilities, and resistances relate to those systems and structures of society that have an impact on our health. So think about a patient's appointment with maybe a sexist or a racist doctor. How much interaction or exposure does a patient have with that doctor? How susceptible or how resistant is that patient to the doctor's claims or biased treatment plan? And this last bit here, this bullet speaks to how the systems and structures use, misuse, or ignore theories that explain inequalities in health. And following that last example, imagine the patient reports the doctor to an ethics board, only to find out that the patient has no standing to report the doctor, or the board says that the doctor followed approved medical guidelines and that the doctor's actions were not subject to those guidelines. You'd be well within your rights to be pretty ticked off about it. So, with all of that said, here's the health issues that some of you might have seen in your own work. Now, what I'd like to do here is just walk us through how social epi sees hypertensive risks that are tied to the social context we've been discussing. And I'll talk specifically within the Black community for this example. Now, I'm going to preface this by saying something I've said before. No group is a monolith. See, we're always going to see variation within a given group. Now, we're discussing what we see at a population health level. We all have different susceptibilities, exposures, and resistances. And those are all based on a number of factors. So with that, let's continue. We're going to talk about economic and social deprivation. So residential and occupational segregation can lead to a greater economic deprivation among African Americans and an increased likelihood of living in neighborhoods without good supermarkets. Now, the risk of hypertension is increased by cheap, high fat, high salt, low vegetable diets. And now, along with these diets, studies also show that economic deprivation also increases the risk of being born preterm, and thereby harming the development of kidneys and increasing the likelihood of chronic salt retention. So that's the line. Now, I'm going to note here that most folks are familiar, I'm assuming, with what we talk about with the social determinants of health. And that is always a good thing. So typically, though, I would see social determinant research go about as upstream as maybe that grocery store, the little corner store here. Now, structural determinants of health, on the other hand, they go farther back and they identify who stands to benefit from such inequities. Now that hopefully you've had a second to sit with how the walkthroughs go, here are a few more examples. All right, up next, let's talk about toxic substances and hazardous conditions. Now, in many areas, this is less of a concern, but the concern itself hasn't completely gone away. Going to revisit our friend here, residential segregation. This increases the risk of exposure to lead paint in older houses and to soil contaminated from lead from car exhaust, and it just sits in the soil. Now, this is usually due to the close proximity of residences to streets or freeways. Now, for those who were here last week, this might start to sound a little bit familiar. Now, lead damages renal physiology, which can increase the risk of hypertension. So again, here's a place where we can talk about how certain neighborhoods were broken up by the initial construction of highways and the systemic, targeted, and intentional decisions that went along with it. Now, if someone here is unaware of who this brother is, please talk to me. I will always talk about him. His name's Khalif Browder, and I'll stop short by saying there's a reason he's here. Sorry, I always feel something when I talk about him. So if you don't know him, go look him up. Socially inflicted trauma. Now, perceiving, recalling, or anticipating racial discrimination can provoke fear and anger, triggering the fight or flight response. Now, chronic triggering of this pathway increases what's known as the allostatic load, leading to sustained hypertension. Now, I want to give you a quick word on allostatic load because this has come up before. So, our stress responses, they stem from what's known as our sympathetic nervous system, or SNS. And this is where our body chemicals kind of shift into high gear to deal with whatever the stressor is in front of us. Like, imagine when you have to suddenly brake while driving. Now, the calm down period comes from our parasympathetic nervous system, or PNS. And this happens after the danger has cooled off or gone away. Now, we experience the effects of allostatic load when stressors like anxiety and the like accumulate in the body. And allostatic overload happens when that SNS stays active and those stressors accumulate to like a fever pitch where we feel like the danger is always present. And that's where negative health effects like hypertension can develop. Well, this is a fun one. All right, so let's talk about the targeted marketing of commodities. Now, I'm not a huge fan of ads in general, so I enjoy this part. So think about all of the ads that we see everywhere. So it's on our TVs, you see it on our smartphones, everywhere you go, that's on you're getting pop-ups on your laptop. You can see them on billboards in public transportation areas or on top of buildings. You can hear it on the radio. And it's everywhere. We are saturated by it. Now, the targeted marketing of high alcohol content beverages to Black communities increases the likelihood of harmful use of alcohol. Now, let's just say somebody is feeling distressed, right? It could be a bad day at work, just something's just bothering you. You can deal with microaggressions all day. It's like, I need to relax. And let's say, all right, I'm going to sit down and watch some TV. Hey, you know what? To have a good time, let me just relax, chill, have a good party. Once you guys have a sip, you'll feel a bit better. That is a single input. And then you look at your phone and there's another ad popping up. Everything's saying, hey, why don't you come to this party? This would be a good time. And you have another input. You see the ads on your computer. Again, you're on your way home or you're just walking through an area and you're seeing these over and over. And the excess alcohol that we would ingest, anybody does really, it elevates the risk of hypertension. Now, this is a good place to ask yourselves about the marketing or advertising in your home areas or any places you visited. These days, I mostly see billboards for lawyer services, local museums, ads for realtors, car sales, stuff like that. But where I grew up, I mostly saw billboards and signs for smoking or vaping, later on vaping, partying, alcohol, bail bonds, and weirdly, a lot of faded outlets. Now, side note, I visited my hometown again a few months back, and although there were some positive changes, the marketing of vices wasn't really one of them, at least not in the parts of town where I was raised. Okay, let's talk about inadequate healthcare. The poorer detection and clinical management of hypertension among African Americans doesn't cause directly hypertension by itself. It does, however, increase the risk of untreated and uncontrolled hypertension. Now, see, in this case, it's less about the risk factors one's exposed to. Now, personally, I see this as the more insidious and nefarious exposure type, where it's about the protections that every one of us should get, like proper screening, follow-up care. However, certain patient groups are systemically deprived of this, resulting in both less protection and more disease. So I get it. Tough week. We've been dealing with a bunch of stuff, and this was pretty bleak. I understand. So I wanted to end these examples on a bit of a high note. So let's talk about resistance to racial oppression. So individual and community resources and social movements to counter racism and to enhance dignity, along with enactment and actively following legislation to outlaw racial discrimination. All of these things, individually and collectively, have been shown to reduce the risk of hypertension among African Americans. Now, what I want to point out is that we just discussed 6 different examples covering only a single group and a single chronic disease. So hopefully you kind of have a better sense for the reach that social epi can have. So think of programs you work with and the disparities you may have seen in your own data. And given those examples, we can consider more in depth about whether inequity plays a role in these disparities. Now, when we go farther upstream by measuring how systems and structures affect all of us, it's really no wonder why there's a little bit of social epi in all the work that we do, if only we knew what we were looking at. And I do have an applied example to show you as well. So this was from my own research some years back. And first to note, this output alone will not explain the entirety of the research, but it does point to that biopsychosocial paradigm that we talked about, and that there are clearly more than biological drivers that would lead a patient to an elective surgery. Also, it calls out the differences within two groups, those being race and ethnicity and federal insurance coverage. It's also, and probably most important to note, and call out how overly generalized these racial categories are. They're terrible. Now, I personally would love to have changed them, added to them, done something different. But as the data were collected and reported like this in the MMWR, I think it was, they took this from, it would have been irresponsible for me to change it based on how I view things. I'm not in the business of making up numbers, so that can't happen. I have to report it based on what was physically available. But if you ever have the option, don't just short people like an entire birthing population by reducing them like this. Okay, so just don't. All right. So one thing that we don't see here is in this first bullet point, which says that the percentage of African American mothers electing into LRCDs, it rose in that original report while it fell for the other two groups. Now, this is significant because all that the report said was that there was a national decrease, which is what we wanted. At the time, I think we were at about 30% of birthing people were having elective C-sections, where the WHO said we're supposed to be around like 10%. So that's a good thing if we're coming down, but why was it different when we dug into the data? And also, separate from this, we see differences in both the percentage and most importantly, the distribution of mothers having fewer C-sections once Medicaid was expanded in the state. Now, this trend was found without variation, mind you, in all 43 US states that were measured at the time. Medicaid expansion, you could say Medicaid expansion preceded fewer C-sections, but the inequities in the medical system persisted. So basically, we got more people into a system that still treated folks differently. So you have to start wondering, how much of a win is that really? So that's just some of my own work, and hopefully this gives a better sense of what social epi is, what it can look like in practice, and how we're all, one way or another, affected health-wise by the societies we inhabit. And most importantly, why we have to address the systems and structures themselves, given that we want our work to lead to longer lasting and more effective interventions and improve everyone's health equitably. So with that, the examples are behind us, and we can just talk from here on in. So I have a couple more pieces to give you. For anyone that's interested, this is just a small list of books that I've come across in my study. They cover a range of perspectives and disciplines, and they work nicely with the references in this slide deck. So hopefully there'll be something here for everybody to enjoy. Now, these, again, they're based on my areas of interest. There are plenty of other areas and topics and groups to consider. So please keep an eye out for works that speak to you. And again, I will make the slide deck available so you can go over this at your leisure. And like with traditional epi, social epi also includes elements of demography and geography, sociology, psychology, biology, all the ologies, all the geographies, all the things. So given this reach, here's just a small list of people that are well known in this field, worth going to look up. But I am going to point out two. One of them, Michael Marmot, out of England, he truly was actually knighted specifically for his social epi work. And it's really cool. Definitely go check him out. Also, In case you are, in case you're wondering that why there's an asterisk here for Dr. S. Leonard Syme, he deserves a bit more attention, and I will get to that in just a second, because he's also very much worth knowing and knowing why we're having this conversation. So, first note, Dr. Syme is credited with the initial development of and work within the field of social epidemiology. And this is going way back to 1958, I think is when he was starting this work and getting recognized for it. And there are many great reasons why he's on that good people to know list. And also, by the way, I have his memoir, and I love this quote from there because it kind of spoke to the kind of good humored person that he is. And with that, there is a link below here to an interview he gave. Now, first, production quality is just so-so in my opinion, so take that going in, but it's worth hearing his thinking in his own words. It really is. Now, the reason for that asterisk earlier and the question mark here now is that despite all the wonderful and groundbreaking work that Dr. Syme has done over the decades, and again, can't be overstated, he might not actually be the first. There's a growing argument that W.E.B. Du Bois was actually a founding father of social epidemiology, like decades earlier. Now, the statistics and the data viz that he created clearly follow the same paradigms and pathways we've just discussed. And they're referenced in chapter 10 of this book here, so feel free to double check it. And I will say this again, this is not taking anything away from Dr. Syme, all right? It's just an acknowledgement that many people over many years have contributed to this work. And personally, I'm a little less interested as whether you were first by a month or a day or second or third. I just care the work's getting done. But really, first, I care that people are given their flowers for their contributions, and especially when they're overdue, like for Dr. Du Bois. And two, I care that we as a society, that we disrupt the structural determinants of health and systemic ills that make this work vital in the first place. All right, great. Well, we made it down to the last word, and the last word is, well, yours. Now, of course, you're encouraged to share your thoughts and experiences, both spoken in the chat, all good. And just in case it makes things a little bit easier for some of us, I'm going to give you a few prompts for us to consider and share with the group. So this first one is asking about you, your experiences, and things you might have seen in your day-to-day. This second one here, this calls back to those long links, again, segregation to hypertension, right? So everything has a starting point. So here's one asking about what speaks to you about health histories, whether they're risk or protective, either way, you want to hear about them. And this last one goes to the heart of something that comes up a lot here in Talking Data Equity. And this is a place where we can talk about possible ways to help make sure someone is and everyone is counted, and what that count means for laws and rules that we all work under. So with that, thanks everybody for letting me rant about my passion area, and I can't wait to hear about yours. And this is my contact info in case anyone wants to get in touch. And now I'm going to go back to the prompts so you can have that last word. Just wanted to say that I really appreciate your time and attention. So again, thank you. And here we go. Let's open it up.
Thank you so much, Dennis. This is such a great day for Talking Data Equity, where we get to hear from somebody who is such a important and regular contributor to all our conversations. I was really looking forward to hearing more about what you're thinking about and what you're working on. And I hope you can see all the love in the chat. And
Thank you.
Yeah. So for folks in the room, if you want to turn your mic on, this is your time to do that. You can absolutely address one of these prompts, or if you have a question for Dennis, this is a good time for that, or a question for the group at large. So if you want to turn your mic on, because there's a couple hundred people, it usually works best if you raise your hand, and you can raise your hand using the Zoom reactions button. Most people right now, I think in the current iteration of Zoom, it's a heart. Hey, Andy, go ahead.
Hi, thank you, Dennis. This was amazing. I just really was getting inspired like with every slide that that turned over. I want to just say something relating to prompt 2 and some of the s- substance use um, health outcomes and behavioral health outcomes and mental health outcomes that we see in indigenous populations, tracing back to their continuous exposure to, I mean, what is has been genocide, you know. Um, so I just wanted to,
Argument there.
yeah, yeah, bring that um, in here, and then supporting data collection for undercounted. Um, I think in in Oregon, there's some sampling methods where there are it's like an iterative way of finding where we need to be sampling more. And I'm not remembering the exact term for it, but anyway, thank you.
No, quite all right. And thank you. And I hope everybody gets to say something too. How you doing? I have my two upstairs. They're not having a healthy day today. So more than welcome. Yeah, that's a very good point. And that's what I meant about everybody finding something that speaks to them. You can look at any grouping of persons that the work from Michael Marmot, Sir Michael Marmot, was looking over the groups of impoverished people and who had to do certain jobs and understanding that the work that they were doing was making them sick because of where they were in their poverty levels. And that's what he got knighted for. So again, super cool stuff. And this was not in a distant past, by the way. This was just a couple decades back. Um, Indigenous folks, that is a wonderful group to look into. And frankly, with the data that I work with, I struggle with that as well. So I tend to look for wherever you can. We talk about Bayesian statistics, other non-parametric testing if you want to get into more of the technical stuff. But a lot of it is going to come back to mixed methods and bringing in more qualitative work to support a lot of the other work that we're doing on the quantitative side. So there's a lot that we can do. Frankly, we should, and getting the right people involved. And I give another talk about measuring racism, and racial discrimination within social epi. And one of the big pieces is talking about bringing in the data, collecting it, but not being extractive, making sure you're getting that information back to the people that are investing in your research. So without them, you wouldn't have work to do. So that becomes a big part of it. So thank you for bringing that up. I will talk about this for the rest of the period and longer. So I'm going to stop here.
There are requests to
Please.
hear that talk, Dennis.
Uh,
People are like, well, we'll have Dennis back because we need to hear that talk too. Let's say hi to, I'm not sure how to pronounce your name. Is it Matea? Oh, you're on mute
Sorry.
still.
Yeah, Matea, you actually got that right. Um,
hey.
I wanted to ask a question because one part of the slides that really stood out to me was when we were talking about the Medicaid expansion and how that relates
Mm,
to the cesarean options. In I work in public health and we try to do a lot to bridge a medical gap with our Marshallese Islander population because we have a
mm,
large group of folks here. One of the biggest hurdles we have is that for this population, they on the islands didn't receive much medical care growing up. And then when people do, they are generally going there to die, basically. And so they have this really rough relationship with Western medicine and a deep
bet.
distrust. And so we have like done a lot to kind of create a space to prioritize them and get them in to our clinic, particularly for things like um, STI testing during pregnancy and also just like general pregnancy checkups. However, we still struggle to work with like the trying to convince people that it is like a safe thing to do to come to the doctor when you're pregnant. And
Right.
so it's like that social element because then it's like we can have a great interaction, but then maybe the grandma or the auntie in the family would say, "Oh, don't go to the doctor." So it's like how what resources do you find to deal with kind of this like intergenerational clash in medical mistrust is, I guess, what my question is.
That one is it's a perennial question, and it's always hard. I am not going to pretend that I have the answers, but I can say there are a couple things that have been at least somewhat beneficial. So keeping in mind that, and I'm going to agree, that was a wonderful question. Think about, that adage about trust taking, a minute to break and a lifetime to make, things like that. So these problems came up and they can last intergenerationally. And it's going to take a while to earn that trust back. And frankly, that's where a lot of it's going to start, is that there are no quick answers for it. If we could, hopefully some of us good folks would have done that already, but we're stuck having to basically upend the ills that have happened to groups of people. And then, of course, like I said, who benefits from that? Why is this happening? One of Nancy Krieger's works from decades ago was titled something like The Web of Causation. Has anyone seen the spider? So check that out if we get a chance to. But that's the idea behind it, is somebody benefited from these inequities and these disparities that we're seeing. And getting people to get past that might not even be the right question to the answer. It's like, what do we do? Again, going back to the chart that I put up earlier, the box plot. We put more people into a system that still treated them unfairly and inequitably. So just saying come in might not get the job done. Probably won't get the job done. You got to go a step back and say, well, what is causing this discomfort? What are the drivers? How can I better meet your needs? And maybe the needs aren't in that system. People may want to go through a doula. They want to go through other persons, and that is also okay. And we just have to kind of get off our high horses, folks within a level of power and privilege, to say that that's okay. What I care most is that you are healthy. How we get there, I will do my very best to get you there to whatever extent you may need it. We don't typically do that. We kind of box folks in and say, once you hit this, you're good. So I would think about it in those terms, is going in, and frankly, we all have to be humble and ask folks what we need to do to earn back that trust. Starting there, I think, is going to pay back dividends. And then eventually we get to the part where we can get people to come in and feel comfortable and spread the word of mouth that this is an okay establishment within which to work. But we can't just jump to the end. We have to, crawl before we walk, and have to get okay with that. And that's hard, but like I said, I don't have all the answers. That's just one way to think about it. And so start with the qualitative, start with the research, going into a community, if, find out what it takes to be welcomed into that community, at least as a researcher. That's another area where people have been systematically disrupted. So you're walking in saying, I have a level of authority. I'm asking you for something. And this has to be about you, not about us. Starting from there, walking in within the light of humility, and hoping that over time, people will feel more comfortable with you. But we've got to give them something to be comfortable. So that's where I would start. Give folks some hope and something to actually hold on to. And then we can get to the other part of the work. We have to upend those knives that have been put in people's backs, not just take it out partially and say you're healed, right? So that's how I would think about it.
Thank you for putting that so powerfully, Dennis. I really, really appreciate it. And great question. Really good question. Megan, thank you for waiting.
Thanks for your patience. Hey.
Oh, of course. Thank you so much for this wonderful presentation. I am an epidemiologist by training, and I do a lot of program evaluation, primarily around child welfare programs and policies. And I'm curious, what you would suggest. So a lot of my work is based on juvenile justice diversion programs. And a lot of times the success or not of those programs is measured by a single variable. They look at recidivism. And a lot of the work that I'm doing right now is trying to convince people that success or well-being is a very complex outcome, and
Yes.
that we need to look at all angles, the sort of whole health approach. And these people have the best of intentions. And so I'm just wondering if you have any suggestions about sort of entry-level conversations or learning tools to help people understand this idea of how social epidemiology really impacts people, and how measurement of an array of variables is really critical when we're talking about the well-being of people, especially who lead very complex and complicated lives. It's kind of a big question, but
It is.
I
That's
feel
huge.
like you're up for it.
Oh, you give me too much credit. No, but that is it's frankly a common one as well. And that's what makes it difficult is that, like I said, if we were able to fix these very fundamental things, you would hope that good people would have already done so and we'd be in a great space. But that's the nefariousness of systems and structures. They work in the background. They work kind of outside of the public eye. And they're just running such that when something comes up and we say, hey, this group is kind of armed, the system says, well, that's an outlier. We're just going to move past that. And we're not going to think about it too much because on the whole, we're doing well. Just like the C-section study. On the whole, rates are coming down. Hooray. You break it out, you find out it's going up for one group. That's another problem. So it's yeah, it's a big, long-standing problem. And I don't have a great entry point to having these discussions because the motivations of the people who are demanding the work may vary. So some people, even within public health, even with the best of intentions, might need to just get grant approval. We just need to get the money in so we can do whatever work we need to do. It might be we have a deliverable that we need to meet. We're doing community outreach and we have a hard number of people to engage with at a healthcare clinic or what have you. The motivations are going to be different. Therefore, the way you approach those folks and say, here's what we need to do and why, they're going to be different. So that's where I would start in finding out who is your top persons without going all the way up to the C-suite. You don't have to do that for this work. And in fact, I'd recommend not doing that. That's kind of the whole idea behind grassroots. It's that if you take care of the small problems, the big problems take care of themselves typically. So start small, start with your corner, start with your organization, and like with your coworkers, and develop a body of knowledge, body of evidence in this case. And you can start to make the case with maybe your direct report. Someone you directly report and say, here's what we're finding. Here's how we can both make best use of our resources such that we can deliver on what we're expecting to deliver on while making good use of the resources we have for those who need it the most. Get that buy-in and continue to push it up and keep pushing it up. And the more you get people that are in other levels of authority involved and on your, I hate to say on your side, but hopefully you get what I mean. Once you're able to make that case, you're able to push farther and farther. And you can also work on it from the policy angle. Because frankly, someone once told us this in my class. They said, no matter what good work you do, community behavioral health, whether it's epidemiology, environmental, none of it's going to matter if you don't understand the policies that are driving these things. So you're going to have to work towards getting policy, whether it's little p policy or big P policy. Frankly, that's a both and in my view. It's the last piece I'll say is the math, the coding, the discussions, the interpretations. It's going to be more complicated than we're used to. I can do a 2x2 table without even thinking about it. I'll put out a contingency table. What do we call it? Cross tabbing. I'll do that all day. that's not going to give us everything we need to know about any community. That's going to help. It's going to be important, but it's one tool of many. So sometimes we're going to have to get into that more complicated stuff, justify it. And oh my gosh, I'm feeling bad about this. I talked about this a couple of years ago, and there's a tool that I developed, and I had to shelve it. I talked about it elsewhere, and it did involve more complicated interpretations of the statistics, which was totally okay. But I couldn't find much support because other people didn't really understand what it was. However, they understood the mission behind it. They understood the work that needed to be done, and they were very willing to support it. So over time, you'll be able to make that case with the right persons to say, this is my group, this is where we're working, and I'm going to do everything I can to make sure that our deliverables are met and we're hitting whatever equity pieces that we need to hit. And we're going to continue to do so as an iterative and growing process. But these problems didn't start from anywhere. Solutions aren't going to just start on their own either. Start small, build it up. There are plenty of people that are doing bigger things, and encourage them, join them, help them. But also, I like working from the ground up. So that's how I approach it. Start small, grow high.
Thank you so much. I appreciate that.
Good luck to us all.
Another fantastic discussion. Thank you so much. And there's also a
That's
couple of
wonderful.
resources on the specific topic that Megan was asking about that people are putting into the chat. So make sure that you check out the chat before going.
Excellent.
Because I think, Dennis, on your idea, good luck to us all is where we will leave it, because we are at the
There.
top of the hour. We are back next Friday, and we have on the same theme. We have kind of an unintentional 3-week theme here. We have some folks that study a project called Mapping Prejudice, where they study racism and oppression being embedded into the built environment. So they're like cartographers and map makers. So it should be really interesting. And the last thing I want to mention just before we go, I am going to take a second to say thank you to you, Dennis, for again taking time out of your busy schedule in a bananas week. And we're definitely going to have you back because people already want the other talk that you referred to. So looking forward to seeing you on the regular Talking Data Equity, but also back as a guest speaker. We have a couple of people talking to me quite actively in the chat, not directly related to this topic, but saying that they work for various agencies and things in the US government, and they are hearing rumors of different data sites being taken down. And I have no inside information at all. I have no way to verify anything at all. But I can tell you, I live in Canada, and a number of years back, when we had a very conservative federal government come in, one of the things that they did was remove a lot of data from data sets that we use on a regular basis. So if there is data that you're using on a regular basis for your project, it might be a good idea to make sure that you have all the copies of the data that you need to complete your projects. So I will just leave it there. Again, I unfortunately don't have any kind of verifiable information, although people are now putting more and more stuff into the chat. So yeah, so probably when we hang up here, if there's data you need, we should all go get it. The other thing I'll say is that we really do want to invite you to continue to attend Talking Data Equity, drop in, use the Data Equity Forum to reach out for the resources and the professional and personal connections that you need as we all deal with a very quickly changing environment. There are lots of people here, and I guess to echo Dennis, when we're working together at a grassroots level, we're going to have greater chance of sustainable success. So continue to let us know what you need. Continue to drop in as you can on Fridays. The Zoom link will not change. And a huge and sincere thank you to Dennis for giving us all something to look forward to this Friday at noon. And I will see you all next Friday. Thanks a lot, Dennis.
Anytime. Don't panic. Organize. Take care, everybody.
That's a perfect last word. All right. Bye,
Take care.
everybody.
Bye.